This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in 2026. It's a case report detailing what the authors call therapies of last resort in a pediatric patient suffering from super-refractory status epilepticus, or SRSE.
This is a heavy topic, Alara. For those listening who might need a refresher on the terminology, status epilepticus is a life-threatening emergency. But when we move into the refractory and super-refractory categories, the mortality rates become staggering.
Exactly. The paper defines SRSE as seizure activity that persists or recurs for 24 hours or more despite the initiation of anesthetic treatment and optimal anti-seizure pharmacotherapy. The incidence is rare, about 1.2 to 3 per 100,000 individuals, but the outcomes in children are grim. We're looking at a mortality rate of 30 to 50%, which can climb to 60% if the seizures are prolonged.
And that's the crux of the problem. Pharmacological management often fails. We use high-dose sedatives, ketamine, immunotherapy, even the ketogenic diet. But in about 11 to 43% of refractory cases, they evolve into this super-refractory state. This paper argues that instead of waiting for the cascade of cerebral damage, the neuronal necrosis and gliosis, we should consider surgical intervention earlier.
Right. And this specific case is a prime example of a multimodal surgical escalation. The patient was an 8-year-old girl with a complex history: spastic quadriplegic cerebral palsy, drug-resistant epilepsy, cortical visual impairment, and bilateral hearing loss. She was admitted in SRSE after a previous surgery, an adenotonsillectomy, seemed to trigger a massive deterioration in her seizure control.
Let's look at her presentation on admission. It sounds like she was in a very precarious state.
She was critically ill, cachectic, BMI of 12.2, with neurogenic scoliosis and chest wall deformity. Clinically, she was having myoclonic jerks, forced left gaze deviation, perioral cyanosis, and hypersalivation. She was unresponsive, reacting only to painful stimuli, and had developed acute respiratory insufficiency and hypotension.
And the EEG confirmed the nightmare: diffuse epileptiform activity. Now, typically, surgery is the last resort because of the risks of operating on an unstable, anesthetic patient in the ICU. But in this case, the multidisciplinary team decided to move forward with a sequential surgical strategy. Ilara, walk us through the first intervention.
The first step was a left selective amygdalohippocampectomy, or SAH. The goal here was to target the epileptogenic mesial temporal structures while specifically preserving the surrounding neocortex and the critical neurovascular anatomy.
That's a key point for the residents listening. When you're in an emergency setting like this, you're trying to arrest the seizure activity and provide neuroprotection by stopping the excitotoxic injury, but you have to be precise. You don't want to add more morbidity to a child who is already severely impaired. What was the immediate result of the SAH?
It was actually quite traumatic. The paper notes that the SAH resulted in immediate seizure cessation. It essentially broke the cycle of the SRSE that the medications couldn't touch. However, as is often the case with complex structural brain issues, the victory wasn't permanent. She had recurrent episodes later.
Which led to the second and third stages of their strategy: the vagus nerve stimulation, or VNS, and the anterior corpus callosotomy.
Exactly. This is what makes this case report so unique. It's one of the few descriptions in the literature of a single pediatric patient receiving all three: a resective procedure, the SAH, a neuromodulatory procedure, the VNS, and a disconnection procedure, the callosotomy.
Let's dive deeper into that rationale. Why add a callosotomy after an amygdalohippocampectomy?
Well, the authors were dealing with a patient who had diffuse epileptiform activity on her initial EEG. While the mesial temporal structures were clearly a major driver, the underlying cerebral palsy and structural damage suggested a broader network problem. The anterior corpus callosotomy acts as a firebreak, preventing the secondary generalization of seizures across the hemispheres. By combining the local control of the SAH with the network-wide modulation of the VNS and the physical disconnection of the callosotomy, they were attacking the epilepsy from 3 different mechanical angles.
It's an aggressive approach, but look at the outcome. The paper reports an Angle Class 2 outcome. For our medical students, Angle Class 1 is seizure-free. Class 2 means almost seizure-free or having rare disabling seizures. In the context of someone who was dying of SRSE, an Angle Class 2 is an incredible success.
Absolutely. They achieved a sustained reduction in both seizure frequency and severity, and perhaps more importantly, the authors emphasized that this prevented the intensive care-related morbidity that comes with months of high-dose sedation and mechanical ventilation.
There's an interesting point in the introduction of the paper that I think we should highlight. They mention that the risk of SE recurrence is highest in patients with underlying structural or metabolic disorders, approaching 20%. This child had quadriplegic cerebral palsy, which is as structural as it gets.
And that brings up the debate of emergency epilepsy surgery. Traditionally, we wait. We wait until the patient is stable, until we have months of data. But this paper argues that surgery can arrest ongoing seizure activity and limit that cascade of damage we mentioned, neuronal necrosis and network reorganization. If we wait until the patient has failed every single ASM and been on a ventilator for weeks, we might be operating on a brain that has already suffered irreversible excitotoxic injury.
It's the time is brain mantra, but applied to the operating room instead of just the TPA window. Now, let's talk about the specific surgical choice of the selective amygdalohippocampectomy again. In a patient with cerebral palsy and generalized findings, some might argue for a more lateral resection. Why go selective?
The authors highlight that the 3T MRI protocol was epilepsy-specific, which helped them localize the epileptogenic zone. By being selective, they minimize the surgical trauma. In a patient who is already cachectic with a BMI of 12.2 and suffering from pneumonia, you want the shortest, most efficient procedure possible.
Good point. The physiological reserve of an 8-year-old in SRSE is almost zero. You mentioned the BMI and the respiratory issues. That makes the anesthesia just as much of a heroic measure as the surgery itself.
Definitely. And the sequential nature of it is also key. They didn't do all three at once. They used the SAH to stop the acute emergency, then followed up with the VNS and callosotomy when the recurrent episodes proved that the single resection wasn't enough to provide long-term quality of life.
So what are the takeaways for the practicing neurosurgeons listening?
I think the biggest one is that the management of SRSE remains unstandardized and highly individualized. While surgery is still seen as a last resort, this case contributes to the growing body of evidence advocating for earlier consideration of surgical interventions. We shouldn't necessarily wait for every pharmacological option to fail if there is a clear surgical target or a pathway for disconnection.
I agree. Integration is the key word here. Integrating resective, neuromodulatory, and disconnection procedures. We often think of these as either-or choices, but in the super-refractory population, they might be and-then choices.
It's about enhancing seizure control and improving quality of life in a high-risk patient group where the mortality is otherwise up to 50%. It's a powerful reminder of what we can achieve when we think outside the standard pharmacological box.
Well said, Ilara. This case report from Child's Nervous System really underscores the evolving role of the neurosurgeon in the intensive care setting. It's not just about chronic management, it's about emergency intervention to stop the fire.
That's all the time we have for today. We'll link the full case report, including the details on the 3T MRI protocol in the show notes.
Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Ilara. We'll see you in the next episode.